So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never want to see another B unless I'm Jay-Z. Farm so hard, let's get
What's good, fam? It's your host, Jim Pruitt, a.k.a. PharmD to ED, and I'm bringing you another episode of the Pharm So Hard Podcast. Of course, we have a special show today. This is going to be phenomenal, and I have one of my good friends, one of my physicians with me today. Go ahead and introduce yourself for the audience.
Hi, I'm Dr. Rosa Malloy-Post. I'm a second-year emergency medicine resident at the Carolinas Medical Center Emergency Residency, and I'm really excited to be here with you, Jimmy.
Yeah, I first got here, I was like, okay, what's something we can talk about, and what's something you're interested to kind of dive into, and we thought about, like, what's a cool thing that no one's talked about yet? And then like a day or two before we did this, someone talked about it. But we're going to talk about it a little differently. We're going to talk about a different study as well. So let's talk about methylene blue for refractory hypotension. We heard it before in other areas, again, for methemoglobinemia, for some diagnostic stuff, a bunch of different things. But the cool part, the sexy topic is going to be the use for refractory hypotension. Because we're tired of seeing these patients come in. We're starting these pressors. We're doing these different things. There may be something else we can use, but everyone's like, well, I don't know.
Oh, no. We'll just wait for the ICU to deal with it.
Yeah. That's the biggest thing is like, are we there yet? I don't know. But hopefully by the end of this, we'll give you guys a different just opinion, I should say. So let's just kind of get into some of the background on, again, tell us more about where you're from. And we know you're a resident, but let's say more about where you're from. What's your favorite beer? All those great things.
So I'm originally from New York, but I went to med school at the University of Colorado in Denver. And favorite beer, I like all swaths of beer. I like an IPA. I also like sours. I think my clinical interests, I'm interested in critical care. I'm interested in toxicology. I love pharmacology. If I could do it all over again, there's a chance I might have been a pharmacologist. Who's to say? I like all molecular biology, chemistry, all the nerdy stuff. So.
Well, you fit right in here at Pharm So Hard. So we're super excited. Again, let's just kind of switch and kind of dive into some of like the historic uses, because I think we hear about this like it's a brand new drug, but we've been using this for a very, very long time. Again, back in the early 19th century is one of the first synthetic drugs ever made. So that was kind of one of the cool part. Like what else has it been used for in the past?
I mean, yeah, it was first synthesized in like 1876. It was used as a dye. And then it kind of blew up in the late 1800s. It's used as antiseptic, an anti-cancer agent, an anti-malarial agent. And then the FDA approved it in 1959 to treat methemoglobinemia. And it's been studied since the 1980s on and off. There's been case reports, a little smidgen here, a little smidgen there, about discussing it in different hypotensive states, especially in vasoplegic and distributive shock. I think the most, at least historically, some of the uses you'll see it most in has been in like post-cardiac surgeries. But that's, it's been kind of gaining speed probably for the last few years in talking about, is this the fourth pressor?
Yeah.
Is this third pressor? Is this something that we can use when we've exhausted a lot of other things?
Is this the new Levophed? Because remember back in the day, it was like Levophed, leave him dead. Yeah. And now it's like the first line agent. Could methylene blue?
It could. Yeah. I mean, Levophed is literally, it's in the water in the emergency department. It's hard for me not to even just like press the button to just do it. So it's almost as easy for me to press the Levophed button as for me to do the vancomycin button. But thankfully, Jimmy has, he's teaching me the ways to actually use the $100,000 of education I've had to actually use my brain to think critically about that. But I think it's coming into vogue and there's a lot of questions. It's not a new drug, it's an old drug, but we're trying to figure out ways to take care of really, really sick people. And I think there's a lot more burgeoning information that's helpful.
Yeah, so we start thinking about like, why in the heck will we use this for a lot of these people are septic shock people. Like, why would we use it for a lot of these people? When we start going back and kind of looking at the whole mechanism and stuff like that, kind of walk us through, like, what do you think about when thinking about, like, how does this drug work? I can get some comments on it, but I kind of want to let this kind of be, what's your thoughts of it.
Yeah, so I mean, it inhibits nitric oxide synthase, and then what that does is it like scavenge all of the nitric oxide, which is like a really, really potent vasodilator. It also prevents nitrous oxide-induced guanylate cyclase activation, cGMP production, and really nitric oxide, again, is just like, it's a smooth muscle relaxation vasodilator. So really in those states of vasoplegia and a distributive shock, that is really kind of the core tenement of the pathophysiology of that. And so this would directly combat that and really work as a good peripheral vasoconstrictor.
Yeah, when you think about like sepsis and all the different processes, I remember when I teach this to residents and students, like this is a very complex process of what's happening. And we know that nitric oxide is going to be impacted greatly amongst all the other things. And it makes sense to kind of target these things at the more of the cellular level as well. And this is one of the agents that we're not relying on an adrenergic system to kind of overcome, which is the cool part about this. So I always think of it as like we do vancomycin because we want to hit everything, right?
Yep.
Well, with pressors is we're going to hit this same alpha receptor over and over again.
Yep.
And hit this beta receptor a little bit, and then that's really it. That's really the cool part. Now we have angiotensin, but we're not a very rich, fancy hospital.
No.
Again, we're a fancy hospital, but I don't know if we are just, the pharmacy department will be okay with me recommending for us to give us a ton of angiotensin. So like, what else do we have, right?
Yeah, I mean, I think there's the data for any of this it's questionable at best, but I think like what we have is, and other therapies of course would be antibiotics early, and then of course steroids as well. So I mean, I think those are like core tenements of treating refractory sepsis, but I think again, those are general pieces, and I think the pressor piece is just a really more interesting nuance. Where we do need to figure out a way to bypass the adrenergic response. So
we're gonna have a lot of acidosis, a lot of internalization from these cells. Again, a lot of our pressors probably won't work as well. So we go through this process, and I think everyone's on board with give antibiotics really quickly, give fluids when you can, give as much as you need to give. Again, I'm pretty sure some people that really goes back and forth about the amount of fluid and the fluid responsiveness and all this other crap. Give that, give Levophed, start vaso seems to be the cool thing now, which is now moved up from, being tied with epi to being like second line now for sepsis. And the reason we did that, because we said epi is hitting the same receptor and doing the same thing, and the data is pretty clear with that. Now, the real question is, in a patient that, again, you throw your ultrasound probe on, you see a hyperdynamic heart, you still see a ton of, hypotension. Now what? After, again, steroids is kind of that next piece that's gaining some popularity. But I think this is where methylene blue has been discussed at least. I think this is maybe more interesting to some people than others, but I think this is where we're talking about it. We're not talking about kind of revamping the whole pathway of treating hypotension in septic shock patients.
Yeah, for sure. I mean, I think it's been dabbled with critically ill patients before, of course, like what I was saying before, with post-cardiothoracic surgery, post-CABG patients. I think there's been case reports about folks in decompensated liver failure, which I think makes a lot of sense pathophysiologically. And then certain drug toxicities, calcium channel blocker overdose, metformin toxicity. So I think we have a lot of room to play, for sure.
Because it seems like, again, before we really dive into the data, it seems like across the board, there's a lot of very intriguing stuff out there, but it's not a ton of big, high quality trials. It's a lot of smaller observational, smaller RCTs, but it's not all in the same condition. Like you mentioned, it may be calcium channel blockers, it may be something else. But I think we're getting to the point now where more people, or hopefully after listening to this, more people will be excited about, let's look at it for septic shock. Let's look at it earlier, potentially, and see where we're going to go. So we're going to transition now into talking about a couple of the studies that I've been talking about forever. All right, so let's get into the thing that everyone wants to talk about. If we're talking about these things and it seems interesting, what about the data? And I know my pharmacists, especially the ICU pharmacists, are like, Jimmy, you better bring some data. So just some interesting stuff that came out lately. We was talking before about this new trial that came out that very recently, and you seem to like it pretty much. So I just want to let you kind of just take it away and tell us about this recent study that came out looking at methylene blue in patients with septic shock.
Yeah, so this was published not too long ago in Crit Care. It's by Ibarra Estrada et al. And it's called Early Adjunctive Methylene Blue in Patients with Septic Shock. It's a single center parallel double-blind RTC. So again, this was in Mexico, a single center randomized controlled trial. They took patients according to their sepsis 3 criteria and either put them in a methylene blue group or a placebo group. And their primary outcome was time to vasopressor discontinuation at 28 days. And secondary outcomes included vasopressor-free days at 28 days, days on mechanical ventilation, length of stay in the ICU, and length of stay in the hospital, and then mortality at 28 days. The inclusion criteria is that they had to initiate methylene blue within the first 24 hours from time of initiation of vasopressors. Okay. They had a broad exclusion criteria, but one of which I thought was kind of interesting was those who were highly likely to die within the first 48 hours, which for me is, we could talk a little bit about more of that later. People who take SSRIs in the last 3 or 4 weeks because actually methylene blue is an MAOI inhibitor, and so it can precipitate serotonin syndrome, which also is kind of an interesting conflict because some aspects of serotonin syndrome might be beneficial. We'll see. And a lot of people in this country take SSRIs. Pregnant patients, and then anybody who's displaying any sort of concomitant or alternative etiologies of shock, so that are not distributive or vasoplegic shock. I think they did a really nice job with how they defined adequate fluid resuscitation and had really nice, multi-times a day, they would redefine their fluid resuscitation, their response. So they weren't just saying, okay, they weren't fluid responsive and then just continue up titrating pressors. Everybody would start at vaso at fixed dose of 0.03 if they met a certain levofed requirement. So if it was equal or greater to 0.25 micrograms per kilogram per minute, and then everybody got 200 milligrams of hydrochloric daily. So it's like a very nice, sort of pretty standard
protocol,
septic shock bundle for the ICU. At least in my very small experience. And so the intervention, they did methylene blue. They did 100 milligrams in 500 cc's of fluid over 6 hours for 3 doses. And then the control was just 500 cc's of normal saline. Okay. The big piece, the primary outcome, they did show the methylene blue group did have a shorter time to vasopressor discontinuation. It was 69 hours versus 94 hours, and that was statistically significant. Okay. And then secondary outcomes, in comparison to the control group, the methylene blue group, they had 1 more day of vasopressor-free days at day 28. They had a lower cumulative fluid balance by almost 750 cc's. They had a shorter ICU stay by a day and a half, and then they had a shorter hospital length of stay by almost 3 days. Oh, wow. All these things were significant. Things that were not significant, which are also obviously very important to think about, is mortality. Yeah. Those were not significant. There was no significant change in adverse effects. So there was no adverse effects on cardiac function, PaO2 to FaO2, of serum creatinine to bilirubin, or any bump in LFTs. So that's, for me, almost equally important, is that there was no change or no difference between those two groups in organ damage.
Yeah, and that's pretty cool. You think about all this because, realistically, we look at the study. It's a RCT. We're looking at 90 plus patients. We're not talking about a couple patients. Again, we had it in one center. So again, some people can make that a limitation, so to say. But it's pretty cool to see that multiple interventions, multiple outcomes were actually statistically significant for methylene blue. And this was early for a lot of people.
Yes.
And I don't know. To me, this is something that makes me say, okay, we should probably look at this and figure out what else we can do with this, because it really makes sense that if we can do methylene blue early, the data is pretty profound in this study. We probably should start to look at something else and see if we can start incorporating this a little bit more, researching it more. I don't know. It's just, when I hear this study, it makes me very excited.
Yeah, and I think what's important for me is that there was no change in adverse outcomes for either group. So I feel like there's only, and maybe it's not what you'd call patient-centered benefit yet, but I think from just a systems perspective, if we can have people, be on less pressors for less time, to be in the ICU for less time, to be in the hospital for less time, for those who survive. And we're taking a swath of patients who are incredibly ill, who are very, very sick. And so I think even these pieces from like a logistic standpoint it's important. So I don't know, like if there's really no significant change in end organ dysfunction in these sick patients, like these people are sick, let's try something, right?
And that's the question. Like, should this be something we just try a little sooner? Because I remember vasopressin at one period of time wasn't just the go-to. Steroids was very controversial, still pretty controversial to be honest. And I'm not aware of any suppressor being able to show in just their primary outcome of just like a significant mortality benefit up front. So again, comparing against other standards of care. So if the only thing that wasn't significant is the thing that's not significant for other suppressors, we should probably start thinking about this.
Yeah, and especially, I mean, we had a patient the other day, and it's like we start going up on the adrenergic pressors, we start going up on the levo, which is what you would naturally do, and then you start having tachydysrhythmias, and then you're fighting a whole other battle, right? So you're kind of at this point where we're starting to just this is all just, we're just riffing off each other and figuring it out. And so if we have something that really is not showing significant adverse events in a large swath of the population, like why can't we try it?
Yeah.
So I don't know. I mean, I think there are adverse effects, right? Like it can cause like significant pulmonary vasoconstriction. So for our folks, our patients who have pulmonary hypertension, who have cor-pulmon, this might not be a great option.
Yeah.
For people who are on those SSRIs, SNRIs, maybe not the best option. People who have G6PD deficiency, which is actually like more common, at least in the folks around here than we let on, like maybe it's not a good idea to do that.
Yeah.
But at the same time, like I gotta say, like I don't see the harm in trying it at least. And maybe people are gonna say I'm crazy, but and I'm a young buck and I'm just thinking crazy, but like I don't know why not. I mean, and this is for people who are very, very sick, and who are just not responsive to other therapies. Yeah,
at least it's something we should start thinking about, you know. It should be a conversation. I know a lot of the pharmacists out there will look at it and say, like, again, they've seen it in, you know, CT surgery or, you know, CVICU, and it hasn't. They will feel it hasn't done too much for them, but it's something we should just look at. I would say. So this one study definitely has made me much more, you know, excited about it. You know, and that's one word we can definitely say. It should make you excited. It should make you intrigued. It should make you want to study it. So that's definitely one part. But there's another, again, that was the most recent that just came out not too long ago. There's another study that looked at this in a similar way. Of course, it wasn't as great because it wasn't an RCT. But Naomi and colleagues in 2022 actually had an observational study looking at about 223 patients that received methylene blue for refractory vasopressor shock in ICU. Again, it's at one center. What they did was they looked at responders, and this was something that we've been trying to figure out who's going to do well. So responders was those that had an increase in 10% in their MAP within 1 or 2 hours of that methylene blue. They looked at outcomes in responders versus non-responders. The cool part was they found that within their group, close to 40% of people were responders, quote unquote, and it had a non-statistically significant trend for better survival. Now, even a trend for me, I won't get too excited, but again, it had a trend at 21.6% versus 14.8%. The p-value was 0.19, so I can't get too excited about that. But even thinking about other studies in sepsis, that's a decent, you know, survival rate for the most part. It is not like some of these other trials where they have the placebo group or the intervention group has a mortality of 50%. It's like, that's not what's smart. That's not what a lot of these other ICU studies are showing. This is kind of right in line. This is what I thought was pretty cool too. They had a subgroup of about 70 patients that was on continuous renal replacement, and they had a significantly lower mortality than the non-responders. Again, the 63.6% versus 89.2%. So I thought that was like super interesting. These are the sickest of your sickest. If they're on CRT and ICU,
it's not good. It's not looking good.
These are the times where you're having the family meetings. It's tough.
Yes.
The cool part is, like, when we looked at all of this, again, there was no difference in gender, age, weight, illness severity, or the dosing between responders and non-responders. We just had to kind of figure out who were those people. Again, I thought this is super intriguing when looking at this. The responders did receive more fluid resuscitation in 24 hours after the methylene blue, and part of that, again, is something I'm still kind of thinking through. But it's something that I want to kind of consider, and comparing this study that kind of showed that, again, you have about 40% of your patient that responds well, and the dosing they were using was, again, about close to 1.5 mg per kg. Some of those patients got on drips as well and using close to like that 1 mg per kg per hour, things of that nature. So I thought this was intriguing, but long story short, this group kind of showed that methylene blue may improve outcomes in responders. Yours showed that it also, show benefit in those patients, and then potentially in those patients who are very sick, the ones that's on continuous renal replacement, it may provide another benefit for them. So we probably should start looking at, again, the thing that this study said is early versus late administration and optimal dosing. That's where I think we are. So just looking at the data, it should make us all optimistic at minimal. And that just really brings up the question, where do you see this used? Again, if you can take a crystal ball, go 5 years forward and say, I can get all the research in the world, where do you want to see this used?
I mean, I think it's very much understood that there's not one quick fix to sepsis. We've tried that, and that obviously doesn't work. There are tenets that, we understand that are helpful. And I think this is going to be hopefully something that's just part of a sepsis bundle in 5 to 10 years. Hopefully, if we have good data and we start having more people actually using it, I think that's where I would hope for it to go. I know there's limitations in cost, of course, but I think there's promise to at least starting to begin to think about doing more studies where we're using it and using it earlier. So I'm excited for sure.
Absolutely. I completely agree with you. Again, we're not saying go out and start this right now, but I will say go out and start studying it right now. Yeah. Like there's a rush to start studying this. Everyone needs to be studying it if we can get the data we need published and have big groups of people. So there's a ton of collaboration we could be doing with different shops. I know like Megan Reck is one of the pharmacists that has her big group of people doing EM pharmacy related studies. Again, a lot of people want to look at this. So if there is people who are intrigued, this is something we probably should be doing. And it should be a rush, a stat order for research on this right now. So it needs to be in the tube station, sent, ready to go.
Yeah, ready to go.
Yeah, I'm excited, man. I think that, again, there's risks. You clearly mentioned them. We mentioned all of those things, but there's a lot of benefits that we probably didn't know about. And it's something we should at least be intrigued with. So all of my pharmacy residents that are looking for seminar topics or different things that need to be done at conferences, like this may be a topic that they should probably look at. And I want to start making sure we look at this in all subsets of people. So getting subgroups to figure out who's the best population.
Yeah.
I think that'd be great.
Yeah, for sure. I mean, I think at least for me, and in decompensated cirrhosis, in a septic patient, decompensated cirrhosis, I don't know, I'm not gonna say I'm gonna try it, but maybe I will, because those, as everyone knows, those patients are some of the sickest and hardest to treat, and they will perish in our emergency department. Yeah. So if I can get ahead of the game with that, maybe I'll try that. I don't know. Yeah.
So we kind of hit a ton of the things. So let's just wrap up. Any closing things you want to go away with from today?
No, I mean, I think it's just, this is an exciting time to be in critical care and to be doing critical care in the emergency department. So I'm very excited to see what more comes of this, for sure. Perfect. Well, thank you for coming on the show. It's super excited to have you. I'm pretty sure it's not going to be the only time we do this. So it's going to be exciting. Thanks to Dr. Fox for letting us use his phenomenal location to record this. And we close out the same way we do with every episode. You don't have to be a pharmacist. You don't work in ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.